only as an analyst, but Health in Americas. I remember her very well in Health in Americas. She was always in demand. Almost all the countries, because she writes well, almost all the countries wanted her to do their final reviews before submission to Washington. So it's my pleasure and an honor to have worked with Margaret. I asked her to come and review their certification in Guyana for us. And I always say to myself that I'm also guilty. As a young medical officer, I used to write when we didn't have a pathologist to decipher the real cause of death. I always wrote cardiorespiratory failure and done all that. And then yesterday, Dr. Morris Edwards also said the same thing, that for HIV, to hide the diagnosis of HIV, some doctors just wrote immunosuppression, and immunosuppression could come from anything, from drugs, from cancer, from anything. So it's a real disease. Well, it's a real disease affecting, the counting of our diseases. The other thing is, if we don't know the numbers that we have, how are we going to plan for them? So it's we are lucky and gratified that Margaret decided to submit an abstract, in this area. So, ladies and gentlemen, I would like to leave the floor for Margaret, to take us through her presentation.
Good morning. I am very happy and pleased to be here. I would like to share with you the purpose of this presentation. The salient purpose is to explain to you that there are methodologies, manual methodologies, that can help you to quantify and analyze your data. And so I'm going to address the mortality and morbidity situation in Guyana for 2016 and 2017. Okay, the team that did this particular exercise was led by me, and they had Ms. Joseph, and they also had some medical coders from the Ministry of Health. There were various medical coders, and so I couldn't put all the names, no? But it was Angela and I, the medical coders. Okay, now, as you all know, measuring how people live and how they die is very important in a country. How they live and how they die. And so in 2016, Guyana had 4,991 deaths coming from all reporting sites. 23 reporting sites, that's the total number of deaths. Males were 2,928, females, as you can see, 2,063. The youngest person that died was 1 day old, and the eldest person, 117 years old. In 2015, this number is 5,786. 2014, down a little bit, back up again, and then lower again. So for that particular year, we had 4,991. Now, let me explain how the methodology. There's something called a book from WHO Geneva called the International Classification of Diseases. That compendium identifies every single thing that can happen to a person in a country. Everything, or the morbid situation or the mortality situation. That is available to everybody. To every disease, we have a code. Every disease. As you can see, I have some examples there. HIV is B20, we have a code for everything. If someone comes to the hospital because they had a problem with their boyfriends, right? And sitting in the emergency room, the nurse says, "Why are you here?" "I have a problem with my boyfriend." That is a code for that. We have a code for that. So whatever you come into the health system with, you have a code for that. And that is why it's important for the doctors to write clearly why you came to the health services. So I have some examples here. B2021, HIV, you have A15, tuberculosis, and something else, right? So for everything you come to the health service, you can give it a label for analysis purposes. And not only for analysis, but for comparison among countries, within countries, and otherwise. Next slide. Again, it's like 21 chapters. Most of the chapters are body systems chapters. We have a chapter specifically for mental health, chapter 5. That's specifically for mental health issue. All right, now, as I said before, mental health disorders and chapter 5. Now, it's important to know that there are specific diagnostic terms that we should use for mental health, all diseases, but particularly for mental health. We need to have specific diagnostic descriptions. So between F0 and F09, organic, including symptomatic mental disorders, every range is a particular disease category. Within the range, we have smaller subcategories. So next slide. Again, you can see for every major category, we have a range of codes. They don't have one thing, doctor writes the diagnosis, we put a code to it. It's easier for analysis, for storage, and so on. Okay, here's an example. F30 is manic episode, F30. Within F30, you have F30.0 hypomania, 30.1 mania without psychotic symptoms, 30.2 you have mania with psych. So the doctor has to give us categorically clear definitions, because if you give us mania, we go to F30.9. It serves no purpose. Mania alone. Be specific in the diagnostic term. Be specific. And for every single F something, we have subcategories. You see? Clear? Very clear? Okay. And we have, so how did we come up with this survey? We had medical certificate of death, 4,991 death certificates in our little warm hands, right? And then each certificate is on a form called Government of Guyana Death Registration Form. Each form has two pieces, a part 1 and a part 2. Internationally, every country has the same death certificate, part 1, part 2. What's different is what you put on the outside of part 1 and part 2. Age, sex, that's different, no? But for us, WHO is part 1 and part 2 is most important. Okay, now, we did everything manually for 3 months. The underlying cause of death is the most important piece of information on a death certificate. Okay, and so if it's not properly done, which is never properly done, we use the US Acme decision tables for classifying cause of death, which is a US-based electronically put together system that will tell us, if it didn't tell us, it tells us the cause of death, which is arbitrary, very arbitrary, but at least it comes up with something that we can use. To do it, it's very difficult to do that, and we have to do that all the time because the doctors write different things, different order. No, we have to use that classification system to enter every disease on the death certificate and eeny, meeny, miny, moe, and choose one based on the act. But if it's properly done, the ICD will help us to just get it. All right. Our analysis used age, sex, underlying cause of death, and regions to do a complete profile for Guyana, 2016 and 2017, by all those variables. We did our analysis. Then it was entered in an Excel spreadsheet. All right, now, the most important piece of the methodology is the definition of terms. Now, when I do with the doctors, right, I will explain to them that this is critical. They should know this. What is the underlying cause of death? That's what we need to get for your 10 leading causes of death. So if you had a traffic accident, which led to concussion, the cause of death is the accident, not the concussion. So the cause of death is very important. The disease or injury that initiated the train of events leading to death. See, not the concussion, but the car accident led to the concussion. So what put the person on the road to death is what is the underlying cause of death. And that's what we look for on the death certificate. Okay, the 10 leading cause of death for any country in the world is derived from that, from the underlying cause of death. Okay, it's used to monitor trends, recognize emerging challenges, and make public health decisions to save lives. The last bullet there, it must be in the first part of the death certificate, part 1. Oftentimes it's not there. It's somewhere else. And so that's when we use the acne to find it somewhere else. Next slide. Okay, the other definition of term in terms of morbidity, and that's where we have a lot of problems in the Caribbean. It's the main condition. When a person is admitted to hospital, we don't want the admission diagnosis, we want the discharge diagnosis. What brought the person to the health system could be a sign or a symptom. No, what was treated is what we call the main condition. So the main condition is the condition diagnosed at the end of an episode of healthcare, primarily responsible for the patient needs for treatment or investigation. If there is more than one condition, and we can't identify one, the one that takes the greatest use of your resources becomes your main condition. If it's a sign or a symptom, and we have nothing else, we use the sign or the symptom. Next. Okay, now, next slide. All right. The analysis for Guyana for 2016 was 4,991 deaths. In 2016, the leading cause of death was ischemic heart disease. Does that fit the profile of the country? It does? Okay. Followed by, there was the first one, ischemic heart by cerebrovascular diseases. The 10 leading causes of death accounted for 86.8% of all deaths. So most of the deaths, right, were in the 10 leading causes of all deaths. No? The 10 leading causes for male accounts for 32.5% and for female, 29.3%. In other words, we look at all the causes for men, pull them out, they account for 30.5%. Next slide. Okay, these are analyzed by regions, no? Now, if you look at the leading causes of death by region, region 1, external causes. External causes are those that happen outside of the individual, the car accidents, the gunshot wounds, the stab wounds, those outside of the normal body system are called external causes. And so for region 1 with external causes, for region 2, external causes, I don't know if it makes sense in terms of the population size, but this is coming from the data, no? From the data. And so region 3 was hypertensive diseases in region 3. Region 4, external causes again. Region 5, cerebrovascular diseases. Region 6, again, external causes. Region 7, heart failure, which is a little general, but that's what we got, heart failure. And then in region 8, external causes. Region 9, external causes. So we have an issue here with external causes of death, and mainly in certain regions. Next slide. Now, something called indigent deaths here. That's something that confused me a lot. Indigent deaths are deaths that nobody claimed the body. They were just in the hospital, right? Now, what was a little difficult for me to understand was that in 2016, there were 180 indigent deaths. They were not registered, so they don't come into our database for deaths in the country. No, so how would you have them dying and there's no cause of death, no age, no stage, or anything? No, it's called indigent deaths or poor burials. And so 136 of these deaths had no age, no sex, no cause. Okay, now we understand that some postmortem was done, but we didn't get, there was no report on the chart as to what the person died of or why they died, no? All right, of the 44 that were left, of the 44 for whom they had some information, 27 were male and 70 were females. These are deaths who are living in the hospital, they die, and that's the end of them, right? And so your death statistics is missing 180 persons who would increase the number of deaths and give you more information to have evidence-based planning. All right, next one. In 2016, there were 61 deaths due to intentional self-harm, which is hanging, strangulation, and suffocation. Males were 53 and females only 8. Region 6, had the highest number of persons dying from hanging, suffocation, and strangulation. I'm not sure, I don't know the region in my head, so I can't explain why region 6. I don't know where it is in my, but it had the highest number of persons, region 6. 21 males and 3 females, followed by region 4, had 17 cases, 15 males and 2 females. In 2016, there were 138 deaths due to poisoning. 97 were men and 41 were female. Region 4 had the highest number of self-harm due to poisoning. Region 4, and you can see men and women, followed by region 6 in that category of poisoning. The majority of persons used bleach, kerosene, insecticide, naloxone, pesticide, rat poison, and we looked at the charts and picked up from the chart what the major thing that they used to poison themselves. Next one. We only had 2 deaths from HIV. 1 man, 1 woman. From TB, which is quite good, 1 man, 1 woman. That's all we had from the data. And remember, we're looking at the actual certificate of death. We had them in our hands. We looked there to get the information. Okay, the results. Yeah, and that's was based on 2017 now, right? 25,592 deaths in 2017. Leading cause that in 2017 was malignant neoplasms. The leading cause of death was malignant neoplasms in 2017, followed by cerebrovascular disease. The 10 leading causes from men took 54.7% of all deaths, female 45%. Now, I have a calculator there. When we're working on the deaths of 2017, that place is called Department of Statistics. They had a different number of deaths. I'm not sure how, because it should be one to the other, right? Now, how did they get more deaths than we had? And so we had a discussion with them, and we decided we would say, let's settle for our number 5592. And later on, when they do their final wrapping up, maybe they have more, maybe they have less. But we work with what we had to get the certificate in our hands. Okay, next slide. Okay, again, for 2017, looking at the regional analysis, you see region 1 had cancers, region 2 is ischemic heart disease, region 3 is ischemic heart disease, region 4 cancer, region 5 cerebrovascular diseases, region 6 is ischemic heart disease, region 7 again cancer. Now region 8, which was interesting, had most of their region 8, they had these high terrain vehicles that are difficult to navigate, and they had access to these high terrain vehicles. So we will spare that out because of that particular region, right? Region 9, diabetes, region 10, cancers again. So we are seeing that malignant neoplasm is quite an important thing to look at within the Guyana context. Again, in the Guyana, there are 150 poor burials in 2017. Only 11 of them had a cause of death. Why those deaths are not accounted for within the system? So the age range from 4 days to 89 years. We had no identified information for 104 persons. So again, that cohort is not in your death statistics, the 4 variants. Next slide. Okay, morbidity data. Again, I say based on available data. And remember, for morbidity, we're looking for the discharge diagnosis, not the admitting diagnosis. And so in 2016, there were 49,091 discharges from all hospitals. All hospitals. Now, the private hospitals did not submit any data. So we're missing again the private hospitals, so public reporting sites. All right, males again for discharge were 36.6% and females 64.4%. Region 4 had the highest number of discharges, followed by region 6. No? And then region 9 had the least number of discharges, only 2.1 from region 6. The least number of discharges region was from the nervous system. That was the least number, 2.1%. Next slide. Now, 5 million hospital discharges in rank order, apart from the ones I mentioned. every hospital pretty much had pregnancy and childbirth as the first leading cause of discharge. Every region except for 1 or 2. Injury, poisoning, and other consequences of external causes ranked second, and third, fourth, you can see them there. The least number of discharge again was nervous system, not linked from the nervous system. Mental health admissions only came to us from Georgetown, no, did not come to us from Georgetown. They included in their general admission. So you couldn't pull out from Georgetown Hospital how many persons were there from mental related issues. It came in their package of morbidity. So where we had data was from the National Psychiatric Hospital. In 2016, they had 163 admissions, and 138 were males, 25 were females. The leading cause for admission from that data from the National Psychiatric Hospital was substance abuse. That was their leading cause, substance abuse. And males 95.8% and females 4.2%. The highest number in age group came from the age group 50 to 34, right? The age group 35 to 44 ranked second. In terms of substance abuse, the first leading cause of admission there. Psychosis ranked second as a leading cause to admission. Psychosis. Males again 81%, females much lower. Again, the group 25 to 34 contributed 27.3%, followed by the other group 20.7%. Next slide. Schizophrenia, which is surprising, was the third cause of admission, which is surprising to me because in the other Caribbean countries, it's the first leading cause of admission, schizophrenia. So it was a little different for me here to see that schizophrenia ranks only third compared to other small territories, no? All right, again, you see the statistics. Age group 45 to 64 was the highest proportion, followed by 25 to 34. All other age groups, 33%. Next slide. All right, now, mental health. After the psychosis and schizophrenia, these were the second ranking. Drug use, psychotic disorders, paranoid schizophrenia. Notice that the vocabulary used on the diagnostic term, right, is specific. It is specific. We don't say schizophrenia. Be specific, right? Paranoid schizophrenia. The verbiage has to be there for us to quantify correctly. No, but we put mania or schizophrenia. It's generic, right? Give us the specific category so we can code it there and we can quantify it within that subcategory. Next. In 2017, there were 52,702 discharges from all hospitals. The leading cause of discharge again was pregnancy and childbirth. Right? 2017, 2016. All the discharges related to pregnancy, majority of them, followed by poisoning, which is not surprising here, followed by poisoning, right? Males 3.6%, females 66% in terms of 2017. Again, at the regional level, region 1, poisoning, region 2, poisoning, region 3, poisoning, region 4, pregnancy, region 5, pregnancy. These are leading causes of admission, discharge. So for region 1, this is poisoning, region 2, poisoning, region 3, poisoning, and you can see all the way down, except for region 8, hypertensive diseases. In region 8. Next one. Mental health. Again, the data only came from the National Psychiatric Hospital. Again, nothing from Georgetown Hospital. In 2017, there were 269 persons admitted to that hospital. 190 males, 79 females. Drug-induced psychosis was the leading cause to admission. 65 males, 7 females. Followed by psychosis, as we saw in 2016, followed by schizophrenia, and saw 2016, the same pattern. Paranoid schizophrenia is added because it falls under the range of schizophrenia, but more specific, paranoid schizophrenia, 11 males and 24 females. All other causes is drug dependence, borderline personality, but you notice that the specific wording of that is important. If it's not worded thusly, then we're going to put it generic, anything. It has to be worded thusly, no? So as to categorize it and count it, quantify it for decision making, no? So you see the specificity, borderline personality, retardation, alcohol abuse, Everything there has to be written like that, or to put it in the right cubby hole and analyze it for evidence-based decision-making. Medication, what are the bad medications based on the specificity of the person's diagnosis, no, or the nurse's training or whatever. No, next slide. Okay. Again, there is a new classification of diseases. It's the 11th revision. We have the 10th, every 10 years, WHO changes the classification. We had ICD-1, ICD-2, ICD-3, ICD-4, we're at 10, now we're at 11. Now, 11 is a different, very different system, 11. We have not yet in the Caribbean moved to 11 because we have not had the training how to use 11. Before we looked at, we had books and we book on 11. Now, no, 11 is definitely electronic. We in the Caribbean don't know how to use 11th revision, but Angola knows that. We should get training on how to use this electronically based classification. Go back to that slide. Go back to that slide. The ICD-11, when we are at 10 now, right? Use an up-to-date and more clinically relevant classification system, clinically relevant in the area of mental health. They have broadened the categories, include a lot more in the categories. Okay. The increasing need to operate in an electronic environment expedited the ICD-11 development. Again, we in the Caribbean don't know yet the 11 because we're pretty much manual. Where we have electronically based things, few and far between, and we don't know how well to use it. So we prefer, as we're doing, the manual way using ICD-10. We should have moved to 11 January this year. We have not moved to 11 yet, but it's an electronic system that we have to learn the process of that. The 11 takes into consideration culturally related information was incorporated in the ministerial review to see what cultural differences, how they affect psychopathology. That's new in the ICD-11, no? And it's expression for diagnostic grouping. Now, these 11, how are they put together? These 10, 11, 12, whatever it is. A group of specialists in their area of mental health meet in Adu-Krow or wherever else to define the parameters that should be included in the classification. Remember, 194 countries use the classification. All of the Dr. Adu-Krow had me go to Papua New Guinea to teach the same thing, because every country has to use, should use the classification of diseases to quantify and analyze their data. Next slide. What did they add to the in the 11th revision? And it's important. They've added some new disorders. No, they've added sleep-wake disorders that encompasses all relevant sleep disorders. They've added hypothonia, sexual health, transgender identity has been added to the 11th classification. They've added bipolar type 2 disorder, body dysmorphic disorder, olfactory reference disorder, hoarding disorder, correlation disorder. These were not in the 10th revision. No, so they're improving as they go along. So in the 11th revision, you have these new categories. No, next slide. Others that they have added are complex post-traumatic stress disorder, prolonged grief disorder, binge eating disorder, avoidant restrictive food intake disorder, body integrity dysphoria, gaming disorder, compulsive sexual behavior disorder, intermittent exposure disorder. All of these have been added to the 11th revision, which we have not started using that as yet because we don't know how to use it. But these are in the new classification, which expands mental health areas. Next. Okay, we'll add others as well. Now, here's a summary of the categories under which these will fall. The large categories. Of course, within each category, you'll have some subcategories. No, so I put a summary of the categories, the larger categories, on which some of the smaller ones will fall. So these are the new categories that they have included: neurodevelopmental disorders, schizophrenia and other primary psychotic disorders, mood disorders. Remember, these are the larger categories now, under which we're going to have smaller categories: anxiety and fear-related disorders, obsessive compulsive and related disorders, disorders specifically dealing with stress, dissociative disorders, and feeding and eating disorders. Again, under each of these, we'll have subcategories related to the larger part. No? Next slide. Again, they've added these new categories. Elimination disorders, all of these, as you can see, have been added to the classification. So in 10, you will not see any of these in 10. But in 11, we'll get to 11, you're going to see these again broken out under them in these specific disorders. All right, my recommendations. Because persons with mental health crisis usually visit emergency rooms, I think the data from emergency rooms should be analyzed, coded and analyzed. We need to know demographics, clinical processes, and the outcomes, right? Because if we miss that population, we don't know where they went. We don't know where they went. And so we're saying that all of these variables are captured when the patient comes from the ambulance or the family to the emergency room. So I think that we should really try hard in Guyana to get a system in place that analyzes the data for the emergency room, right? Because some of them are sent home medication. That's it. No, so where are they in a numerical count? Where are they? And that's my recommendation for number one. Of course, I had several others, but for this particular conference, this is one of them. Next slide. That's it. Oh, okay. The other thing that I noticed, like yesterday, there's a lot of prison activity through mental health, a lot of prison activity. Now, I think that we need to understand, again, to code the data of those inmates who are incarcerated that have mental disorders, and so we can know who they are to plan for them. How do we know how many of them have schizophrenia, have this and that as well? How do we know that? So if we have a particular system in place, with a person there in the system that can analyze, collect and analyze the data, you can plan better for persons who are incarcerated. The last slide is fine. No, I have a minute. Reading. Very interesting reading. Very interesting reading. Very interesting. It gives you
that slide up.
very interesting reading.
Yeah.
Yes. It highlights everything to do with the acid reading.
Well, thank you, Dr. Hazlewood. Now the floor is open for comments and questions. Yes.
Dr. Hazlewood, thank you very much for an excellent presentation. You've given so much information that raises a lot of issues that, one, I don't want to dominate the floor, and there's so many that I can't go into them. But first, let me start by making a plug to the conference organizers, that this should have been, you know, when we go to international conferences, you have a plenary session. This should have been a plenary presentation, because this outlines for Guyana the broad context of morbidity, mortality, and you've gone down so in detail about mental health, and really outline that would then sort of parachute nicely into the other areas. Yes. So, Dr. Adu-Krow, if this can be taken to the conference organizers, that maybe in their organizing they can look at having a full plenary presentations, and which will sort of dovetail into the other areas. And if we can get Dr. Hazlewood to come back, you know, and shed some light on that. All right, so that's one. Two. So I'm going to zero in on some issues that you raised. The indigent deaths, where there are, so people die. We don't know where they come from or whatever, and so on and so on. And it's surprising. And so maybe sorry, I should start by saying that it's a pity that policymakers of Guyana Ministries of Health are not here, because this is extremely important for them. And that knowing Dr. Adu-Krow that this information somehow should be transmitted to the Guyana Ministry of Health. it's appalling to know that we have these 100 or something indigent deaths in 2016 and no postmortem is done. To understand the cause of death, it might be saying something about our behaviors in the country in terms of our care for the less fortunate people and us as professionals, and so for the policy makers. All right, so why? So in the cause of death, this person is not important, and we have, and this is happening primarily in Georgetown, because Georgetown Hospital, and we have a pathology, the major pathology department in this country there. So for me, that one was appalling. What I want to look at is that in 2016, the question here, right? In the 10 regions of the country, 6 of them had external causes of death. And when you did the summary before we drill down into that, the leading cause of death was ischemic heart disease. Region 4 was one of the regions that had external causes as a leading cause. There seems to be some disconnect there. And would you want care to for some sort of explanation
why?
as to why? Or what does it seem to you as a contradiction? Right? Because for me that's a clear contradiction. Because if ischemic heart disease is one is your top, but then here 6 of the regions in the country, so something is wrong, something is sort of wrong here. Then we come to 2017, where cancers, and so malignant neoplasm, the major cause of death in 2017, some 10.6%. I did an analysis of the cancer registry from 2000 to 2010, and there were some 8,513 cancers. This is a publication from that was supported, and neoplasms was the 4th leading cause of death. When you compare that with what was there's a bulletin, statistical bulletin that the ministry used to publish. I don't know what's the position with that. It seems to be a contradiction, unless there has been an explosion in cancer cases, and yes, in cancer cases, and then that, well, so those people in terms of care that they've been dying in droves, that cancer overtook ischemic heart disease. So would you care to give some views as to did it raise any question in your mind that changed from, I know this is what the charts actually reveal, but the disconnect there, and what would you recommend to us in terms of how to try to tease that out, and this has to be some disconnect. Region 8 is 27. The region 8, you don't know the regions of the country, but what you highlighted, the all-terrain vehicles as a major cause of death. We have a full explanation for that. It's one of the mining districts. Yes, and when people have to go to the mountains and go wherever to seek that, they use the ATVs a lot. And Dr. Adu-Krow had the experience of riding on one of those because I was there with him. So that may not be a surprise for Guyanese or persons who have experience with the country as by that. Those just giving an explanation. What I find also, if you could provide some explanation, when we look at morbidity data, that maternal and child health conditions form the bulk of discharges. But if our deaths in 2016 were related to ischemic heart disease, so either people not going to hospitals for these conditions, or there is misclassification, or misdiagnosis or misclassification or whatever the case might be. But there seems to be a disconnect that people are not classifying the deaths, sorry, the conditions correctly. But that jumped out to me that you were saying one thing in terms of mortality. Morbidity is showing us something. People just writing anything. Oh, everything is related to maternal child, maternal and child health. And there was one other point that I wanted to raise: mental health. It seems as though the persons who are doing the diagnoses and writing, that they are very much versed with ICD classification, because you were able to point out there as to what they were actually reporting. In terms of very specific schizophrenia, mania, so on and so forth, so that it was easy. I'm assuming, because it's your well, that's the impression that I'm getting, that at least for mental health, we're able to have that. What would be your recommendation for the other areas, or sorry, did you find similar or something different for the other diseases, the difficulties that you had, and then what would be your recommendation to them? So, like I said, they got quite a lot, and I hope that you were chatting the question. By the time you want me to refresh, I can always answer the question. I mean, much more to this stuff.
Well, thanks so much, Dr. Edward. Let us have 2 or 3 yes, and then Dr. Edward will answer.
I'm Dr. Daniels. I don't practice anymore. What I have found, not only in Guyana literature, but there's always a shortage of pathologists. And here in Guyana, I'm told there's only one pathologist. It spends one day here and one day there. And you have 2. You have 100%. And doctors who have to write out the death certificate, there are times when they're not certain the cause of death. And then when you don't have an autopsy to confirm, even the practicing doctors are still not, they're still ignorant of the management, and they're still missing some of the cases, yes? Just as we also have a shortage of psychiatrists in Guyana. It's not just Guyana, but it's worldwide. How can we in 2022 get an exponential change in providing sufficient trained pathologists? We can't just take it one at a time. We have to find some drastic method of leapfrogging, getting the doctors interested in training. And training is difficult because worldwide there's a shortage of pathologists. But how can we get that? I'm not sure how to praise the word, but how can we make a leapfrog in providing a higher quality of diagnosis of death and subsequently assist in the management of patients along the line?
Well, thanks so much for the question, and I wouldn't profile any answers before Dr. Hazlewood speaks. Yes.
Dr. Bashir. I have one comment and then 2 questions or points of clarity that I need that sort of are in line with what Dr. Edwards asked before. So in your presentation, great presentation, by the way, it's a lot of information to digest, and the way it's presented becomes a little bit difficult to look at because you have to be reading lines instead of like having a graph that usually it paints a better picture. So that was my comment. So in terms of questions, I was also wondering the same point that Dr. Edwards raised. In, for example, in 2017, you said that you had over 2,000 discharges, and the majority of those were from closing NCH discharges. And so if we have roughly about 40,000 to 60,000 per year, then the majority we're just touching about of those discharges. How do you classify the others now to say that? How do we get an idea what exactly are these discharges? You presented on your morbidity data, and mentioned that in region 9 there was a low discharge rate, and I was wondering why people were dying more there. The other point that Dr. Edwards also raised is, for example, in international health metrics for the top 10 causes of death. In 2019, they showed that neoplasms was actually at number 9, and so you had cardiovascular diseases, diabetes, hypertension, and so on. Even chronic kidney disease being higher than neoplasms, which you raised with probably around 6% of those, right? And so if your data in 2017 says it was number 1, and then in 2019, we have a report that says it's at 9, compared to how do you explain this big drop? And then again, a point that he mentioned about the ICD classification. We have not been trained in evidence yet. I know the staff department was making some revisions to actually have this training done this year. They have not been successful as yet. So they wanted to retrain in 10 and then also retrain in 11, their host. So his point that you mentioned is how are they so precise in classifying that? So I was wondering if when the stats department, for example, gets the death certificates, do they go back and like read through the charts and reclassify for them to be able to get this very specific classification that you mentioned? So it goes right.
All right, let me before Dr. Hazlewood comes, because this particular consultancy, we thought it was very necessary, so PAO supported that, and a lot of what you see happens to be actual chart abstraction. I had to visit where they were working, and they had 5 to 7 Ministry of Health staff, because they couldn't do the chart abstraction by themselves. They had Ministry of Health bring in charts, and when I went there, charts are all over. So some of the diagnoses that you see are actually derived from chart abstraction, because like both of you said, doctors don't, at least me, I don't know that those fine details to be able to come up with that. So, but I'll let her speak herself. A few comments also from me. I saw mental retardation, and I thought we've moved away from mental retardation, because if we say that someone who has a mental condition is retarded, then that explains why I'm not seeking mental health advice. So I think ICD-10 persons who work for that should really look at the mental retardation issue. External causes, I'm glad that both Dr. Edwards and Bachan mentioned the external causes. I was shocked to see the external causes by themselves. And then I was saying to myself, the external causes, do they equate to self-harm or suicide? Because suicide and self-harm are all external causes. So if our main problem happened to be suicide, then those external causes, were they actually intentional self-harm? I was also shocked that 136 deaths had no costs. The indigent deaths. I think Dr. Edwards said so. I think we need to know what is killing our people so that we can plan for it. Self-harm now. Oh, you had mentioned that the West area was region 6. Now, according to the last data, it's now moved to region 2. But that's just a note. I was also shocked that the 10 leading causes of death. Normally, we tell countries, dwell on the 10 leading causes of death, and you capture the most deaths that are killing your people. And then I realized that when we looked at the data, for the various sexes, for men, it was around 50-something, and for women, So I was saying, in that case, even if we give advice to countries, look at the 10 leading causes of death, then we will still be missing other ones. So probably maybe that's something to look at. 2017 had cardiovascular diseases and cancers and no external causes, and I was surprised. There were a number of poor burials, and I think as all the three speakers and all the three persons have mentioned, I think we need to, and that's not your problem because you are only taking what is there. I think we need to do better. My other question is ICD 11. When are we moving to ICD 11 before in 10 years time ICD 12 and then we are still at 10? Because the things are being refined more and more, and we need to look at that time as Caribbean people. Gaming disorder, I was surprised to see that because I am, in my retirement, I'm doing a lot of gaming. And I saw that and I said, oh my God, now they have a I even told my wife that when I die, they should put PS5 in my coffin. And so, gaming disorder, when I saw it, I put 3 question marks up. Am I there yet? Dr. Edwards said it so well. This should have been a plenary session issue. And then before we started, I was even not thinking about the plenary session. I was saying to myself, where's CMO? He needs to hear what is killing his people. And so where's Chief Medical Officer? Where are the other directors in the ministry? And I think, like I said, Dr. Edwards said it so well. And I wrote in my notes, shame that Ministry of Health persons who make decisions are not here. Emergency room coding and analysis, I think we have mentioned that. So those are also my comments. So we have 4 different comments, and I think we have stepped on each other's toes. So maybe you can answer them.
Okay, first that.
And if you forget, please come back with any person that she may forget.
Firstly, as I've always said when I do workshops in hospitals, right? In a particular country, there's a certificate. Remember it has 2 parts, part 1 and part 2. Last loose line is for the underlying causes. The last loose line in part 1. So this particular country, the only line used was the first line. The cause of death is GOP. Was the cause of death. What's that mean? What are we? So it's really the doctors don't understand how to write a proper diagnosis. I have another certificate that says RIP on the first use line, nothing else. RIP, rest in peace.
As a diagnosis.
RIP on the first only line used. They were the GOK. The point I'm making is, first, we examined all 4,991 death certificates, everyone. We are not medical doctors. I'm PhD in something else, and those are medical codes with some training in anatomy physiology and some training in terminology. Now we can only code what the doctors write. Who are the doctors? The medical certifiers who certify the deaths. Whatever they write is what you code. And so when the issue becomes, the coders don't know what to do, it's not us, it's the doctors. And I've trained them in most of the countries how to write a specific diagnostic term and to understand what is the underlying cause of death. Because if you're going to put underlying cause of death as a concussion, that did not set the person on the road to death. It was a car accident. See, so those don't understand the terminology. Underlying cause of death is that situation that put the person on the road to death, whatever the situation is. HIV, that's where it started. But the first time HIV before, it's not the underlying cause of death. So the particular question that was raised, we quoted exactly from the where we didn't understand the sequencing, because how it should be written is the last used line should cause the one above and cause the one above. That's how it should be written. The last used line the car accident led to a concussion and led to pneumonia. The person was lying at the time. So that's the sequence. Doctors don't know that. So we take it in our hands certificate. If we understand within ourselves the sequencing, we can sequence it and find the underlying cause, which is hypertension or whatever it is. Now, if we don't, the arbitrariness comes in with the acting. The automatic classification of mental entities that the US uses, that's what we have to use. It becomes an arbitrary decision because if the doctor enters 4 different diagnoses and none follow the sequential pattern, we have to list the code for each of the entities in part 1 and part 2. And then the act will tell us, choose this one, the underlying cause. Clear? Right. Because the doctor didn't write the first place. So if we have both books, so when we cannot identify the causal sequencing, we have to code a case law to code every entity on the certificate, 6, 8, or 10, right? In part 1 and part 2, and let the book choose for us the underlying cause. So that could explain anomalies that you're seeing. The second issue comes up discharge, hospital discharges. The doctors usually, and we have the chart in our hands. So we have thousands of charts all over the world. I go to each chart, I go to every chart. Okay, now the doctors usually write the admitting diagnosis, not the discharge diagnosis. That's why the term was the issue that was treated within the hospital is the main condition, not the symptom and signs. So what we have seen is that symptoms and signs are listed as the discharge diagnosis. So we can't go, first we can't change the chart. So you can go to the chart and look at the nurse's notes, which is more informative than nurse's notes, to see what is the what was treated for, right? And then we can't change the document, we can change it on the system. That's another issue, right? The doctors need to understand it's not the sign or symptom or the condition, it's what the person was treated for. And key phrases at the end of an episode of care. In other words, if the person comes in with a fractured leg, right? That's an episode of care. Now, if from then he's transferred somewhere else, another episode of care. See, so we need to see the episodes of care to understand the discharge diagnosis. And so again, we work with the actual data. Now, whether the queries and the anomalies that you see from region to region, we don't know because we're not comparing. So we don't know the regional perspective. What we have in our notes would be the region, population, the finding cause of death, and when it comes to the whole picture. So we have in the report, the ministry asked us to tease out some specific diseases, and we teased that out for the ministry. They want specific diseases teased out, right? And we did that, but we cannot operate with the data that we had. Now, it was strange to us that the Bureau of Statistics had a different number of deaths compared to what we had certificate for. I met with them 2 or 3 times, and find they got a copy of the certificate, it's certificate, they got a copy. Maybe they don't have a person there who does the actual coding or timely coding. No, because if it's not timely, you're going to have different figures. So we have recommendations for that as well. That there should be some liaison in the Ministry of Health and that entity. Other questions again?
Let me also add to that. Apparently, during this same consultancy, we realized that the entity that does the registering of deaths, you just mentioned the name.
GRA?
No,
Bureau of Statistics.
Yeah.
They actually don't close mortality data till 15 months. So they said that, oh, well, anybody who may have died, let's say 2021, we still don't know as yet. Because they will have to wait till all the data comes in and they give a whole year plus 3 months and then finalize it. So anything that comes after that is out.
There probably is an explanation for that. Guyana is one of the countries that has to have its mortality data checked by Carrefour, and because they're using Mortbase, right?
Right.
Right, and we've had that same problem trying to get current data. And so it takes about at least 2 years for that. And so maybe that is what they are waiting for, that finalization. Yes?
This pathway from the hospitals, where it is coded at the level of the hospital, not too much at the regions, no. In Georgetown, no, they're coded there. It's transferred to the epidemiology department. From there, it goes to CARFA. From CARFA to PAHO, Washington. From PAHO to WHO, right? Now, it should be at least a year behind this fact. Some countries, including Guyana, are years behind.
Right.
So we came here in 2018 and in 2016 and 2017. And so one of the things that could improve things is more trained coders at the regional level.
Right.
So when they bring data in, it's already coded to be verified by the Ministry of Health coders. The other thing, coding is considered a clerical job, not a professional job, clerical job in this country. For example, the Bahamas is a professional job. In the Bahamas, you have the coder doing rounds with the doctors. She can understand the patient's issue. And when she sees the child, she knows the issue. And so, but the larger problem with the doctors, the larger problem, I make you laugh at it. Somebody in the mountain was sick, way up in Jamaica, mountain. So George gave me that. And the doctor went up far to the mountain to see the patient. But it's too far to go back a second time. So he left the certificate, get it out. When you die. And so George told me, but I was asking for some funding for a workshop. And he said, doctors don't care. I train them, don't care. And gave that joke. But it's real. In a particular country that I train, it's this much death certificate to be entered. And that's why everybody has cardiac arrest. Cardiac arrest. Now, it's an acceptable death, but is it cardiac related? It's a heart related condition. So when you give me cardiac arrest, it's a junk code. If you have some junk code, then cannot enter into the database for the junk codes, right? And so the training of the doctors is very important. How to write correct diagnosis, right? It is, and don't blame us. You write something, you don't quote what you write. See, so that's the doctors have to understand that they start the chain of statistics for a country. What they write is the chain of statistics for the country. So where is the anomaly, right? It's because we code what we see from the charts. So the anomalies are in there based on a certified issue. No, how can we fix that? We did some training by Dr. Adu-Krow brought me some training. The doctors that we train should train their incoming staff. They should train what they know to incoming staff. They're post up some hospital with their poster, but nobody cares about understanding the doctors begin the chain of statistics for a country. The doctors.
Two things. One, let me start with what you mentioned there. And so maybe because we really don't have a statistical unit in the country.
Yes, you have.
We have statistical. No, my office is. I used to sit with them, and as you say, in many countries it's not clerical, it's professional, right? And so when I say, but it is in that context I'm talking about. We really don't have a unit. And so the strengthening of that unit so that you have this ongoing training. Because usually what happens in Guyana is that whenever a new batch of, especially for persons, most of our doctors are trained or used to be trained in Cuba. Whenever that batch comes in, the office of the chief medical officer does an orientation in the story. Right? And so what this study has shown is that there needs to be ongoing training, not just for the new people, but I know when you're going to 11, everybody, there must be ongoing training. And unless you want to put that under the office of the chief medical officer and that strengthen that they get support,
put that under statistical unit, my recommendation in terms of that. No, coming back to the question, I still don't think that the question, I might be wrong, but I still don't think the question has been answered. Where in 2016, ischemic heart disease was the leading cause of death. But 6 of the 10 regions, including region 4, which has at least a third of the population, 200 and something thousand in region 4. And region 4, major cause of death, when you break it down by region, was external causes. There's a disconnect between the two. And so, could you try to answer? I know if you didn't answer that, but could you try to answer that now?
Can't answer that because I work with my available data.
Okay.
I can't answer that. Again, I'm an outsider. I don't know the regional characteristics to say what begins, what is feasible. I don't know that. I can only work with data.
But I think what Dr. Edwards is saying, these are numbers game.
Right.
So if the original analysis, they have different numbers, then those numbers should also translate, right? When you look at it at the exam.
But I think the report itself should inform the Ministry of Health. Say, here's something we can look at.
Yeah.
How can we understand it better?
Right. Okay.
The Ministry of Health, when they get the report, they should only ask questions, and seek further clarity. Because we can only work with what we have.
I was going to ask how the student think the powerful virtual training, the free course on how to properly take that certificate. It's free.
Yes.
It's useful for our section, and then if it is, then why aren't we using it? Why aren't we recommending our professionals to be trained?
I think it's there, but I think some countries have asked it to train. I think they prefer a live interaction than just, what to call it.
If we can get to that point, we can draw more money to get to be able to train and we like that, yes. But can we start with?
Of course, and the ministry can recommend the doctors, the ministry of the doctors, here we have, use it. I think that's a good idea.
But you use it as a CME
The CME,
every now and then.
yes. The other thing is about the death certificate, as I didn't is we have never seen any deaths from maternal cause, except for pregnancy. The death certificate surely has a piece on it that speaks to was the person pregnant when the person died. It should be on the certificate. Was that person pregnant when the person died? To capture your mortality rates. Yeah, it should be there. But my strong recommendation, because we need to understand how many women die pregnant.
I know one thing, quickly. One thing that startles me is Dr. Hazlewood just presented this, and immediately you've been able to catch some things that don't add up. But I'm surprised this report was given to CMO. And they were not able to analyze that. Oh,
If we don't read, we cannot analyze.
Thank you. Thank you. We just don't read. I mean, and here we ask, okay, can we delve a little bit deeper? Why is this the case? Why, 5 years after the fact, you guys are now picking up issues that reports that were given to CMO.
That's going to minister, make sure it's not more than 2 pages. So
It's 78 pages.
Right, nobody's gonna read it.
24 recommendations.
No. I've never practiced medicine in Guyana. I was trained away in Asia. And what I realized when I came back is that the quality of training and practice in Guyana, we're still immature. There's still a long way to go with the doctors training and the doctors in the clinical practice and the administration. We're years and years behind other countries. And the mindset is such that a large proportion of doctors who are trained and practice here migrate. And the interest is to want to stay and make a career up there and to go into these little areas where specialty or where training is required is not readily available to them. And we don't have the leadership to say, okay, we're going to get 10 persons and send them to be trained as pathologists, or we're going to get some psychiatrists. So we have Dr. Harry as one of, you understand? So it's not just from the top, because the young doctors coming up don't even have their mind stimulated that they are these areas where they can go and train and come back. And that urge for improvement is our greatest handicap.
I think the majority of our people are trained outside. So I wouldn't blame it too much on training, but I think the culture that they come into, and that needs to be changed. Yes, Dr. Edwards.
Yeah, just quickly on that, it's the accountability and the monitoring.
That's cool.
And again, it comes back to roles and function, where Ministry of Health with the health sector reform was supposed to be looking at setting these standards and doing the monitoring.
Right.
But Ministry of Health is still heavily involved
Exactly.
in implement, so it's not performing its function. Yeah, that's for me. That's the major. That's the
No,
major
it
problem.
is.
But I have two questions. One is that we didn't get data from the private sector. True. And so we don't know, while many of the same doctors who operate in the public sector operate in the private sector, there are still some who operate purely in the private sector. And it would have been good to then make a comparison to see the practice.
Yeah.
Yes, and the difference. So one. But you no longer with PAHO, is there?
Yeah. Can I put a plug in there? I think in terms of morbidity data, yes, there's a massive difference. In terms of mortality data, nobody wants dead people in their hospital. So mercy, when it gets so bad, oh, go to GPAC, so they go and die in GPAC. So in terms of mortality data, the differences will be minor, but morbidity, definitely.
Okay, so fine, but still we need to have that. And maybe as a form of PWR, in discussion either with your colleague who's still there, or folks at Washington, and or with the Ministry of Health, we're missing that. Because this and you said it, the objective one, evidence-based decision making. And in my experience, a lot of what we do in this country is not based on, so it comes back to the culture. We don't use evidence for actual decision making. So my recommendation would be for there to also be, even if it's just a look at what came out of the private sector in the same period, and then do a comparison. Yeah, so that can also inform us going forward. I forgot what was my second.
Okay, for the period of time that I worked with the DMO's office, some private institutions would send a monthly report to the DMO's office. Everybody would send their own structure of a report, and then that report doesn't get moved to anywhere else. It doesn't go to the stats department. Nobody then from the stats department knows it exists to then go and check with the private institutions. Hey, are they validated?
So see, we're not performing our monitoring. People submit to us.
Yeah,
we don't utilize. So. And they don't get feedback as to whether it's useful, they are following what is the standard, they need training or whatever, so. Yeah.
We worked for 3 months in the office of the CM, in her space we worked. But we're only given charts from the 23 reporting site. I don't know, government's funny. Not a report said this came from Mercy Hospital. No, we were given the reports from the national health facilities. That's one thing. The second point I want to raise was training of doctors. The number of charts that we reviewed were in Spanish. Number of charts. The diagnosis in Spanish.
In Spanish?
Yes.
Yeah, they're out of A at the end.
That one.
No, but some of the words were not diagnosed in English. And so there was a doctor in her in church, and the same was I remember her name. Then she just in Cuba. Then go ask her, what does this mean? What does this mean? So what meant to that in Spanish?
Was the doctor not too?
Yes. Yes. We had to ask her because we didn't know why it's diagnosed term in Spanish. Yes, I understand Spanish, but the diagnosed term I didn't understand. So the monitor is important. And the pre-training of the Cuban doctors is important. I taught in Greenhouse. I taught same course on completing the certificates in Greenhouse. And the doctoral training had different underlying cause. You know, training in English-speaking countries. It's not like cause, so same case. So there needs to be some further, not training, further something to bring them in to understand our disease patterns and the language. That's one. So I think that in order to get a better picture of evidence-based on there's something that must happen. One, like you said, the doctor should be trained using that standard electronic version. Two, a revision of their certificate, right? With an explanation of was the person pregnant when the person died. The third thing is we have to professionalize the codes because they're trained in every country in the region. And next time they train, they're not there anymore. They've moved upward because there's no respect for them as a medical code. No respect. No. One girl in St. Lucia, she has this many charts to code and can't understand the diagnosis, the discharge diagnosis. So what she has to do, go to the emergency room, tell her that she's not feeling well. And the doctor calls her in, she said, hey, fix things. Go to St. Lucia. Because there's so many charts to do. In Montego Bay Hospital in Jamaica, this many charts to be done. So the CMO said, you know what, no vacations. So you finish the charts, no vacations. So we have strict overseeing of the doctors to make sure that they don't keep the charts forever and then put schizophrenia. One other country, everybody has schizophrenia. Everyone could have too many charts to code. You see, so we need to look at the system here and make some dramatic changes.
3 quick comments before Dr. Adu-Krow wraps
I just wanted to add that your recommendation that coming from Dr. Edwards that all this must have all morbidity and mortality data, whether private or public. Just to add what you.
Yeah, 3 quick comments. One, follow up with it's appalling that so we can't stop belaboring the point. None of the policymakers is here. But what is even more appalling is that this report was being submitted to them since when, and there seems to have been nothing done. So this was an academic exercise for them. So some plug needs to be, somebody needs to be there, please. This, because it seems that we go down the same path all the time, and we're not going to improve. And Guyana is in the spotlight now, right? Is in the spotlight, and we need to change the practice. Secondly, you ask about when will ICD-11 come on board? 12th of never, because it's electronic, right? And that is going to be a massive problem with regards to that. Forget the third point, but just those two that before you give your closing remarks.
Well, I must say that the other thing that I wanted to add is every year, chief medical officers are supposed to write their annual reports. So where do they get the data from? Where do they get the data to advise ministers that, the leading cause of death in our country is diabetes, so let's plan.
We could.
Exactly.
Because we had data up to about 2019 that
Thank
was
you.
finalized. And so we go online and you're like, how come Power has 2021 data? How come Global Can has whatever, where they get it from? And so those resources you're citing, which you ask the stats department. They're like, we don't have that, we don't have that, we don't have this.
Quick comment on that, because the surveillance system is disjointed. There needs to be integration. Cancer information goes from the cancer registry, which we in the report that we did, a recommendation was made for strengthening. They don't have somebody to analyze their data, right? And even still externally, they've asked me, they send and say, okay, look, could you help us in terms of what the incidence is and what? And so I help them to just say based on the number of cases that you have for that year, this is what your incidence is. So they're able to report in terms of that.
From the old data.
But this strengthening the needs.
The disparity in the data, the same program gives you incidents for this, and then they send you another report 1 week later with a different incident.
Okay, so we have problems. We have problems.
Yes, yes,
We have
yes.
like,
No, definitely, definitely. Yes, please.
At the regional level, the interior regions, right? There needs to be somebody there who's trained and analyze the data. At a regional level, yes, right? Because in the high priority, the important news, remember that right word, right? There is somebody there. We go to the interior where they die and they bury. What did they die? One of the agents.
GOK, that's what they do.
Okay, right? So that pool of information is not in the database because they died, they buried in the woods somewhere. So a restructuring of the health information system needs to be considered, right? We're bringing all the deaths from everywhere on the same level, coded, analyzed, and presented.
quick one.
Yes,
Dr. Adu-Krow, PAHO support, we have an MPH program in Guyana, which was specifically designed for the needs of Guyana. One of the requirements to be a regional health officer is it must be trained in public health. PAHO supported, I have my excuse with that it should have come out of the national budget, the Ministry of Health budget, supported the training of a number of persons to be trained at the Masters of Public Health level. Have we placed those persons? The first cohort, 60% of the space was allocated to the Ministry of Health. Cohort of 20, that's 12 persons. Correct. 21, that's 12.
correct.
Not a single person from the Ministry of Health was actually trained in the MPH program. And what our recommendation was that the people who go out as regional health officers with that training,
Correct.
yes, they administer health in the region, but at least the ability to do analysis of their data, because we don't know that we have the resources to have an epidemiologist
Correct.
in the region, but
Correct.
if the regional health officer is trained
In MPH.
in to an MPH level, they can pardon?
Most are not, they didn't join the Guyana program.
Okay,
But most are.
so why is there,
Oh, no.
so there should be
Oh,
an
no, but-
analysis data?
What did they tell you? Because I don't have anyone to help me to do anything, so I can't analyze.
But the present RHOs, most of them don't have MPH.
Surprisingly.
So, well,
They have it on paper, whether they, actually put it in that.
Okay.
I've had my mouth full. I'm sorry.
well, I must say that I think Jamaica, they say we are small, but we're lower. We've had a small audience, but personally, I have enjoyed it. I've enjoyed it because, not because of the inadequacies within the system, but the fact that we don't seem to learn. Because we brought Dr. Hazlewood in here because we were told by the ministry in 2018 that the data that they had was up to 2014. So we said, okay, let her and team medical coders that you bring together for her to train, bring us up to date, and then you continue. We're back to square one. So I think we need to learn from that. But anyway, I would want to summarize with these few recommendations that have come from EFO. Yes, ma'am.
No, just asking out of curiosity. Were there any questions online?
Ma'am, any questions online? Okay, all right. Well, thanks so much for the reminder. So our first recommendation, all death certificates, public or private, should be analyzed and coded and sent to a central point.
There's
Oh,
a comment
okay.
specifically what about this.
Is there a comment?
Yeah.
Okay, can you read the comment to us, please?
Great presentation, but like the document here in how do I get about it?
All right. All the presentations here are going to be online. The abstracts plus the actual vocal presentation and the slides are going to be online. They asked us whether we can pay to have it put online within 2 days, and obviously we can't pay. So UG, this lady and her colleagues have decided to give it, to do everything for us and assure us that by January we should have it online, because they are involved in UG activities and therefore they could not split. I mean, they've given us their time free. So we will have everything online in January. You go to the Guyana Mental Health and Wellbeing site, and you have it in January, everything. The second comment? Whether she can get in touch with Dr. Hazlewood or me? With me?
Yes.
I'm not a movie star. Well, yes, write to the GWB, our email, she should write to us. If she goes to our site, she will find our email and she should write to us. All right, so all their certificates, private and public, should be analyzed. We talked about standardization so that we are all having the same diagnosis, if at all possible. Like I said, I'm glad that they have one for me, Amy. Margaret kept on talking about pregnancy status because the diagnosis changes whether one person is pregnant or not. So I think we need to be mindful of that. Professionalization of coders. I mean, Dr. Hazlewood kept on saying that, and that if we take them for granted, we will also have to take whatever they put down for granted. So we need to see them as professionals who are trained, in their own business. And then the fact that policymakers are not here is a shame. I haven't seen CMO here the whole period. And then Minister has been here twice. I think he's here today, which is good. But then some of the directors also have to be here. But anyway, we talked about ICD 11. I think Dr. Edwards mentioned that if we cannot even get ICD 10 correct, then it's going to be difficult. I was told, and Dr. Hazlewood can correct me, that ICD 11 is a little bit more difficult than ICD 10. And if it is, then we need to, all countries, we need to start the training now. Otherwise, they'll move to ICD 12 and we are still at ICD 10. And when we are reporting our diseases globally, we will still be behind, and our diagnosis will still be generic, because then ICD 11 is more refined. So I think we need to, yes, please.
Cannot move to ICD 11 unless we have finished calling on all the data to 10. You can only move to 11 when all your data from 2020 backwards are in 10. You can't move data from 10 into 11. There's a new data set.
So that means that probably those of us here, we should contribute and have a consultant come and help the country bring it up to date, because I don't see it happening.
That's you ask for overtime pay to get the data out of the
Houston, we have a problem. That's Apollo 11. Yes, sir.
In August, I got a birth certificate I had applied for. And when I looked on it, my application was submitted since April last year, right here in Georgetown. And it took all those 8 months just for a birth certificate issue. And we keep asking the question, get the cohort of people, pay them overtime, and bring everything up to date. And that is just that simple part.
Yeah.
They used to be way back in so many areas.
Yeah. No, I totally agree. On behalf of the everybody who participated in the session, I would like to thank the presenter. She's in demand the whole of the Caribbean, so we are glad that she was able to make it to spend some time with us. Dr. Hazlewood, thanks so much for your presentation, and we hope that well, a lot of people are asking for it. We will send that also to the ministry again, and hope that we will be able to generate some enthusiasm. Thanks so much for your time.
Thank you very much.